Since a passive fit is required to seat a zirconia crown, how do zirconia EZCrowns achieve strong retention? Every one of the EZCrowns that we send out have what we call Zir-Lock grooves, and those grooves are actually mechanical grooves that are milled within the internal surface of our crown. And that does a bunch of different things. The first is it increases surface area. And the more surface area, the more bonding you have. Nothing likes to stick to zirconia, and that includes cements. So what do? Well, we did what we thought would be normal for anybody that was coming up with a new technology, and that was to create a mechanical retentive feature within the crown so that whatever cement you chose to use, you could go ahead and use. So the grooves go all the way down from the occlusal surface, all the way down on the lateral walls, and that helps with dislodging forces both straight up and down as well as lateral forces. When it comes to zirconia crowns, or any pediatric crown for that matter, you have two bonds that are actually important for the clinician. The first one is the bond of the cement to the tooth. The second one is the bond of the cement to the crown. And with EZCrowns and our Zerolock feature, you don't ever have to worry about the second one, which is that bond from the cement to the crown. We have that one taken care of. The macro retention that's in there is really gonna hold those crowns on. It's been over 10 years now, you don't have failures between the cement and the crown. But where you do have failures are between the cement and the tooth. I say a lot, in a variably moist, unpredictably contaminated field, what's the best cement to use? And if I were to poll 100 doctors, most of them would say a glass ionomer cement. So that's one of the reasons why when you ask me, what cement should we use? I'm always gonna say, well, a glass ionomer, a pure GI is probably gonna be your best choice. And that's because it's gonna work in that variably moist, unpredictable environment that is pediatric dentistry. So those are the main reasons we have the Zerolock grooves. Now, another one that's very, very important that a lot of times we don't think about is, I'll be talking to somebody at a show and I'll say, when you cement your zirconia crown, you know how when you push it down and the cement squishes out, you let it set up a little bit, then you take your Explorer and just flick that cement away and it comes away really super easy? And they'll nod at me and say, yeah, no, I know how that works. I said, well, how do you know that the whole distal lingual wall underneath that crown didn't just flick out? The cement flicks out so easy, and remember, in pediatrics, we have cement margins, which means if you flick that cement and it grabs underneath that crown, you could flick out a lot of that distal lingual margin that you would never know. Well, one of the things that Zerolock grooves do that's really important is they actually, like I said, they go all the way down on the inside walls. And so that cement, they almost act like a perforated card. So when you break the cement, it breaks right there at the margin, ensuring that you have a nice cement margin. All right, what is the best way to achieve hemostasis and ensure a clean placement of the crown? Hemostasis is one of the things that's a challenge, especially, when you've got the little mouth breather, the little 3-year-old vaulted palate, mouth breather, you look at his tissue, it starts bleeding. We've all had those kind of cases. So hemostasis can be a challenge. One of the things that is different with zirconia crowns is you do have to prep a little bit subgingival. So remember, when you're prepping subgingival, really take the tip of that burr and tuck it in and push against the tooth axially. And the reason why is if that burr is away from the tooth and it's just out there in the periodontal ligament and it's out on the tissue, you're gonna create a lot of bleeding that doesn't have to be there. I'm a dental anesthesiologist, as a lot of you guys know, and I always tell people the best place or the best way to prevent an emergency or to treat an emergency is actually never to have one. So I would go back to this question and say the best way to achieve hemostasis is to minimize it or limit it based on the way you're prepping the tooth. Now, that doesn't always work. We're gonna have bleeding regardless, especially when we go subgingival. So there's a couple things that can be used. One is direct pressure. It always works the best. So a moist 2x2, squeezing the teeth together, pushing apically, hold it for a couple of minutes. Now remember, it's direct pressure. It's not, all right, is it done? I see people do that all the time. They go back and forth, and it's gonna take more than 5 seconds. So really once you get the crown seated and they fit nice, remember, have the assistant rinse them out with water. She can drop them or he can drop them into some peroxide that'll help to bubble out that blood to make sure that they're nice and clean. So if you have peroxide, that's another thing that's really nice to do. If you can put a little bit of peroxide on some cotton and squeeze, that works as well. One of the challenges with a lot of the new delivery systems of cements is they're great because they're so easy to come out. Well, anytime you're using an auto mix, remember it's going to be a little bit thinner. So if you have a really, really bad bleeding case, hold pressure, make sure that you hold it, push apically, wait for the assistant to fill your crown. Make sure the entire surface of that internal part of that crown is full. So don't leave, don't just fill up 80%, fill it all the way up. Make sure that on those axial walls on the inside, they're nicely full of cement. Because when you go ahead and seat that crown, remember holding pressure, take it off, grab the crowns, put them on, hold them in place for about 30, 40 seconds till the initial set of that cement happens, and you should be good to go. Do you have any tips for removing the cement? Why, yes, I do. One of the things when it comes to cementing these crowns is it's important when you cement the crowns, remember, back to the basics here, zirconia crowns don't snap into place. So you're gonna need to hold them in occlusion until they set up. Whether that's in the anterior, hold them in place for the first probably 45 seconds or so until that gel, the cement starts to go into that gel phase. Also in the posteriors, you want to make sure you hold it down because remember, normally the snap of that crown will keep it in place while the cement dries. A lot of times I think people do this and they don't realize it. They'll cement a posterior tooth, let go of it. The hydrostatic pressure of that cement will push the crown occlusally a little bit, and then they'll have a little bit of a high restoration. So you really want to make sure that you hold them in place until they get to that gel stage. Now once they start getting to that gel stage, that's when you can start taking an Explorer, pushing apically against the tooth and the cement, and it just flicks off, like we said earlier, flicks off nice and easy, doesn't stick to the crowns. It's a really simple cleanup. You can also then take your Explorer and kind of fish it through the interproximal papilla, get everything that's down below that contact area. You can also use, in pediatric dentists we use knotted floss a lot. Take a little knot, floss it through there, as well as super floss can be used as well just to pull it through and get all that extra stuff out. So it's kind of a tight in between. Some people do the power wash, though, especially in the posteriors, they'll hold it in place, spray it with a lot of water and suction. If it's below the gums, that's fine to do. You're not going to wash stuff out. Some people take a toothbrush and just brush it vigorously, buccal lingual to get it all off. So there's a lot of different ways to do it. Just make sure that you don't start cleaning up too early. And the flip side, don't wait too long because once that stuff gets really hard, it's sometimes hard to get it underneath, from underneath that contact area. So great questions. So if you have any other questions, we want these to be more like a Q&A type of a thing where you ask questions, we give some answers, clinical challenges, all those kind of things. So if you do, feel free to email me at askjeff@sprigusa.com. We're also looking forward to bringing on some other pediatric dentists and talking about some of these questions and some other things. So stay tuned.